us in presenting the first abstract in this session on HIV and non-communicable diseases, as I thank the people for attending this session. Thank you. Sandra.
Thank you so much. Good morning, everyone. My name is Sandra Murwira from Zimbabwe Technical Assistance Training and Education Center for Health, zim-ttech. And today I'm honored to present our work titled Beyond the Screen, Evaluating Post-Treatment Outcomes of Women Living with HIV Screened VIAC Positive in Harare, Zimbabwe, 2024. This work focuses on what happens after treatment, a period that is often invisible in routine data, yet specifically important in preventing cervical cancer. Women living with HIV are at a higher risk of cervical cancer due to their increased susceptibility to persistent HPV infection. zim-ttech has been supporting cervical cancer screening and treatment across 5 provinces in Zimbabwe since 2018. And by the end of 2024, a total of 71 static sites and 325 outreach sites had been established. In 2024 alone, nearly 100,000 women living with HIV aged between 25 and 49 were screened. The main screening method is visual inspection with acetic acid and cervicography, while HPV testing is gradually being introduced. Out of the 5 provinces, Harare achieved an impressive 97% treatment rate in 2024. However, the national guidelines not only emphasize treatment, but also require every woman to return at 6 months for post-treatment review, because without follow-up, lesion recurrence is a significant risk. Therefore, we zoomed in on this critical post-treatment period. Our main goal was to evaluate the post-treatment outcomes for women screened and treated between January and June 2024. We specifically wanted to know how many women completed their 6-month post-treatment follow-up visit. We wanted to know how many screened VIAC negative at 6 months post-treatment. And among those who screened VIAC positive, we wanted to know if the recurrence rate differed by the treatment method. This map shows the Harare facilities that we included in our analysis. Harare is Zimbabwe's capital and is a metropolitan province. It has high screening volumes and offers both excisional and ablative treatment options. These facilities represent a realistic picture of an HIV care urban setting. We conducted a retrospective review of the cervical cancer screening and treatment registers at the selected sites. Our population included women treated between January and June 2024. The treatment options that were used are LEAP, thermoablation, and cryotherapy. Then we assessed the outcomes. This is the screening result, the treatment type, as well as the proportion of women who returned for the post-treatment follow-up, and the VIAC result for those who returned. We analyzed recurrence patterns using chi-square and Fisher's exact tests. This allowed us to check if the recurrence differed by the treatment method. And these are the results. In total, 3,358 women were screened. Of these, 231 screened VIAC positive, 8 had suspicious for cancer lesions, giving us a positivity rate of 7.1%. Of the 231 women, 214 received treatment, giving us a treatment rate of 92.6%. This already demonstrates a strong program, high screening numbers, high treatment completion. And so the journey begins as these women have to return for post-treatment review. Just to show you the treatment methods that were used, the majority of the women were treated using thermoablation, followed by LEAP, and the least with cryotherapy. Of the 214 women treated, 204 were eligible for follow-up because 5 had undergone hysterectomy, 3 had transferred out, and 2 were pregnant. Of the 204 that were eligible for post-treatment follow-up, 177 returned, representing an 86.8% post-treatment follow-up completion rate. But 13.2% did not complete the follow-up. This gap may appear small, but it's very significant because it translates to real women who are at risk of progression to cervical cancer if recurrence occurs but is not detected. Amongst the women who completed the follow-up, 87% screened VIAC negative, which is encouraging because this indicates that the treatment was successful. However, 13% screened VIAC positive again, which means there was recurrence of the precancerous lesions. This recurrence rate is consistent with the global trends for women living with HIV. And here we just analyzed if the recurrence differed by treatment type. The recurrence occurred at similar rates regardless of the treatment method. There was no statistically significant difference. This suggests that the follow-up system is rather than the treatment method alone, is a critical factor in long-term prevention in ensuring long-term prevention of cervical cancer. In conclusion, 13% of the women living with HIV who were treated did not return. They had recurring lesions, which means they remained at risk of progressing to cervical cancer. The recurrence did not differ significantly by the treatment method. 13.2% did not complete post-treatment follow-up, which means also these women remained at risk. Strengthening follow-up systems is essential for sustaining treatment gains. We therefore learned that our recurrence rate aligns with global evidence confirming that women living with HIV need vigilant monitoring. Treatment rate is very high, showing capacity for strong clinical delivery. However, despite the good overall treatment rate, follow-up remains a gap. Therefore, strengthening tracking and linking post-treatment follow-up with routine HIV care could significantly reduce this gap. We also learned that recurrence did not differ significantly by the treatment method, suggesting that prevention is not just about screening and treating. It is about closing the loop with effective follow-up. Our next steps are to investigate barriers to follow-up, conduct clinical reviews of the recurrent cases, and strengthen systems that link post-treatment follow-up with routine HIV care. I would like to thank the Harare City Health and zim-ttech teams, the Ministry of Health and Child Care, CDC Zimbabwe, and the women who receive care at the sites. Thank you.
Sandra, are you a teacher?
No.
Because you present so clearly. I've seen the presenters here struggling to keep within the allocated time, and they end up failing even to deliver the message. But you have exceeded those standards they set. Thank you very much. So you have heard from Sandra, and we have the privilege now to ask her more questions, since I have not seen any other presenter that is going to come in. The first question I have for Sandra, I have not understood how those who had recurrence, how were they managed eventually? I did not get that. You can clarify that as you answer to the questions from the floor. Now over at the floor, question 1, yes, then question, may I see about 3 hands? Yeah, 2. Those are 3 questions, so thank you. Yeah, you can move these 1, 2. And I would love a question from a lady, because this is a lady's topic. Yes.
Thank you very much for the great presentation. My question is, of those who were not treated, a number of them were because they were misdiagnosed, according to the slides. How did you pick this up? I mean, what protocol did you follow to pick this up? I want to understand that. Thank you very much.
Thank you very much, Sandra. It's a good presentation and it's eye-opening. So my question is for those with the recurrent, were there any additional underlying medical conditions, for example, like diabetes or any other thing? Thank you.
Excellent. As we gather more questions, let me give Sandra an opportunity to answer that first round of 3 questions, and then people can ask more. Sandra there.
Thank you so much for your questions. I'll start with responding to the first one that asked about management of the recurrence cases. So if during post-treatment follow-up, a woman screens VIAC positive, the lesion is reassessed. Like I said in my presentation, we use visual inspection with acetic acid and cervicography. So we have that picture that gives us the type of lesion that is there. So if the lesion is eligible for treatment with ablation, it is treated right there and there, because we offer screen and treat. If it is eligible for excisional method, then referral is done if that site does not provide excisional method. Because all the sites are able to provide ablative methods, but excisional treatment method is limited to certain sites. And there was a question that asked about those who were not treated because of misdiagnosis. So when the woman is screened at a clinic, a picture is taken, and if the nurses who do the screening think that this lesion needs lip, they then refer the client. But once the client reaches the lip center, the doctor will also reassess and see if there is a lesion before treatment. So if that picture during that session is then VIAC negative, it then means it was a misdiagnosis from the first initial screening that was done. So we classify that as a misdiagnosis, and they end up not getting the treatment. So this happens over a time, and that's how we are able to get the data, because we analyze it like that. So we've been having, just for your information, we've been having quality assurance meetings to ensure that there are less and less of these cases. And then the question that asked about underlying conditions for the recurrent lesions, unfortunately, we did not go to really look at that to see what contributed to recurring lesions. In our capacity for the program, we do screen, we treat. If there's recurring lesions, we treat. We only treat up to a 3rd time, and we refer to a gynecologist if there's persistent lesion recurrence. And so maybe the woman would need maybe hysterectomy or things like that. Thank you. I think I've answered for the first round.
Yeah, maybe any other additional morbidities, yeah? For those who were found with lesions beyond HIV, did they have any additional underlying conditions, diabetes? Yeah? I don't know whether it has been answered.
It has been answered. It has been answered. So like I said, for the program, for the analysis that we did, we took records from the cervical cancer screening and treatment records. So on this, the variables that we have are to do with cervical cancer screening. We didn't go on to link, but I guess it's another area of focus that we can go on to analyze and see what happens there.
Like I said, you look like you deliver your material like a teacher. So I am sorry for having missed that. Any other questions from the audience? That's one gentleman. Any other from a lady who is interested? Okay, so the gentlemen have taken it from you. Thank you.
Thank you very much. A very insightful presentation. I don't know whether I got you clearly. You did mention about, is it 13% who never either turned up, or I don't know if they are lost to follow-up or something like that. I don't know, what do you think would have been the reason why they never turned back? Thank you.
Okay, thank you. So I guess this is the final question. Also, like I said, 13.2% did not complete the post-treatment follow-up. And I suggested this as another area of focus for us to really look at the barriers for post-treatment follow-up adherence. Because out of our minds, we can just think of other things. Maybe they had traveled, maybe they were just waiting to come when they come for their other ART visit, or we don't know. So it's an area, like I said, the post-treatment follow-up was not receiving the focus like the routine indicators, screening and treatment. So it's an area where we really need to look at further, to analyze and see what was happening there.
Okay, thank you, Sandra, very, very much. Unless there is any other question, I think let us give a hand of thanks to Lady Sandra. Please don't go. This chairman would like to take record of having interacted with you here, as the tradition is. I'm not sure whether the other presenters are online or not yet. Anything? Okay, nothing. That answers time. Yeah? And I think let me extend my thanks to the vibrant audience we have had today. Thank you very much. Today is the last day, but you showed interest to come for this. The IT team, thank you for not wobbling through. It has been a good delivery. And finally to Sandra for doing an excellent job. Now I would like Sandra to accept that we have a photo, and the chairperson and my head of unit at WHO is around. I did not introduce myself, but I'm Dr. Kagwa Mugaga, working with the World Health Organization at the Uganda country office, but my senior from the region office is around. And I would like to invite her to come and we have this photo as we close this session. Thank you.